So welcome everybody. I'm Dr. Clare Spencer. I'm a GP, a menopause specialist and co-founder of My Menopause Centre. And we are so grateful to consultant ear, nose and throat or ENT consultant surgeon, Miss Vicky Ward, for giving up her time this evening to talk with us. So welcome, Vicky.
Thank you, Claire. Very kind of you to invite me.
It's great that you're here. I'm really looking forward to this chat. So I'm just going to tell you a little bit about Miss Victoria Ward, a consultant ENT surgeon at Mid York's NHS Trust and Spire Methley Park and Spire Leeds. Vicky's been a consultant ENT surgeon since 2005 with a subspecialty interest in rhinology and paediatric ENT. She completed specialty training at Guy's and St Thomas's, Great Ormond Street, with a fellowship in Zurich, and has now landed in the north in Yorkshire in Leeds. She's been editor-in-chief for ENT UK's e-learning, for ENT Project e-learning for health, and she's passionate about training and education, as you'll hear this evening. She's director of e-learning on the ENT UK Education and Training Committee, completed the Emerging Leaders Fellowship at the Royal College of Surgeons England, and a JCIE Intercollegiate Specialty FRCORL HNF examiner. So lots of letters, extremely well qualified, and currently chair of the West Yorkshire Associated Trust ENT network, standardising the delivery of high quality care to patients in West Yorkshire. So we are really fortunate to have you here. Main interests are rhinosinusitis, role of new technologies, and developing training and access to specialist ENT surgeons. So we're going to be talking about tinnitus, dizziness, vertigo, mainly this evening. Please feel free to put questions in the chat, and I'll maybe try and weave them in as appropriate, or we can tackle as many as we can at the end. We've got 30 minutes. We've got a lot to cover, so we're going to crack on. So Vicky, many women, we've just been chatting about numbers, but many women report to me that they experience symptoms such as tinnitus, vertigo, dizziness in the menopause transition for the first time. But when I was scratching beneath the surface, trying to find more about it as a menopause specialist, I couldn't find that much written about it in relation to estrogen and the menopause. So I wonder if we take those in turn, and whether we could start with tinnitus. If you could just explain a little bit about what it is before we then move on to estrogen and its role in the menopause.
Certainly. So thank you very much for inviting me. So tinnitus is an extremely common ENT symptom, very often expressed or complained about by patients. Of the order of 10 to 25% of all adults complain at some point or other of tinnitus. What is it? Well, it's the perception or hallucination of noise when no external sound is perceptible. It comes in the forms of buzzes, rings, roars, whistles, hums, clicks, and it's whatever the patient describes it to be. We don't really know what causes it. We're unclear as to what specifically causes it, but many patients complain of hearing loss. And so hearing loss is probably the most well expected or accepted cause. If you lose your hearing, you then start to process. And the theory behind it is you're processing neuro stimulus from the cochlea to the brain or somewhere along the auditory pathway. It's often associated with noise exposure, with hearing loss, with changes in medication, blood pressure medication, aspirins, many caffeine, for example. We like to make sure patients don't have wax in their ears because that can block the symptoms. Patients describe it associated with TMJ joint dysfunction. So any clicking of the jaw joint can be perceived in the ear and can be remarked upon as tinnitus. There are very few but rarely diagnosed causes of serious tinnitus, and they come from growths on the nerve of hearing, such as what we call a vestibular schwannoma or an acoustic neuroma, but they're extremely rare. Where does estrogen come in? And you ask, what do we understand by estrogen? Well, there are estrogen receptors all over the body, as we know, but there are some estrogen receptors in the cochlea. There are undoubtedly patients who complain of fluctuations at different stages of their reproductive transitions. So puberty, during pregnancy, a lot of estrogen receptor mediated processes occur, and that's not uncommon in the transition into menopause. Similarly, patients complain about odd sensations. Those are all thought to be neurochemically related, or in relation to feelings or sensations of buzzing and tingling in their hands, their feet, and all over. And these things are often associated with tinnitus. So we believe it to be a perception of neurochemical transmission, and that estrogen receptors play some part in that.
Yeah.
The hair cells in the cochlea are pre-programmed to wear out, but they're still moving, and we perceive that sound. If we lose our hearing, which is something else that happens as we age, and the estrogen receptors in the cochlea are deemed to be responsible for the loss of hair cell function. When the hair cells stop functioning, we don't perceive high frequency sound. And as we age, that gets worse decade on decade. So the association between loss of hearing and tinnitus is very well borne out. And if you lose high frequency sound, so the top end of an orchestra or a female voice, for example, you can't discriminate those sounds, you may well hear tinnitus that is high pitched as opposed to low pitched or a buzzing, humming tinnitus, which is associated with a low frequency hearing loss. Because at different parts of the cochlea, we perceive different frequencies of sound. And so there's some relationship between where in the cochlea these estrogen receptors may lie. Is that related to why we, if we take HRT, are we protecting those neuroprotective pathways? And that's
Wow. Gosh, so that's fascinating. So just to recap, could you just remind us about the cochlea and where that sits in relation to the ear? Because it's fascinating.
So the cochlea is the inner ear, okay? It's part of the cochleovestibular system. So that controls your hearing, your sound perception, and your balance. And it's variably blood supplied. It has a very small blood supply. So if you have high blood pressure, or you have had previous problems with, you've got two blood cells that are stuck together, it's very easy to compromise the blood supply to the cochlea. So there's a lot of relationship between migraine and vestibular migraine and cochlear phenomenon. So people perceive changes in pressure in the ear. Your hearing mechanism is dependent on three parts: the outer, the middle, and the inner ear. And the inner ear is what we're concerned with today, because that's directly affected by estrogen. The middle ear is also potentially affected by estrogen, but not directly, indirectly by its effect on the eustachian tube and its connection to the nose. So if you have nasal symptoms, congestion or dryness, then your eustachian tube may not function properly, which will change the pressure across your middle ear, which will then upset your inner ear. And so you get fluctuations in your hearing.
Wow. Okay. So I think things that I've learned from that. So hearing loss you can actually substitute sound at the frequency that you might be losing, and you might be losing certain frequencies as a direct effect of loss of estrogen and its activity on the inner sound processing bit in your ear.
And the problem, there are lots of things that affect the inner ear. So fluid balance in the body. So if you drink too much caffeine, you're dehydrated, then the balance of salts across the perilymph, which is the fluid that's in and around the ear, and the endolymph, which is inside in the cochlea, it will alter with changes in your hydration levels. Similarly, medication can cross into these barriers. And so that's why medication and caffeine are deemed, and salt, for example. If you have a high salt diet, you can be secondarily dehydrated. You may not feel thirsty, but that doesn't mean your inner ear isn't suffering. So when I come across patients with Meniere's disease, which we know affects endolymph, that is also something that people start to complain about in later life. and can be due to direct fluctuations in the salt content in the inner ear.
Yes. Okay. Okay. So I suppose that brings us then on to what can we do about yes. Yeah.
So there are lots of things that we need to do. So obviously we like to exclude the worrisome and serious causes. So if the patient is just complaining of tinnitus and nothing else, and they're not necessarily part of a symptom complex that is experienced in menopause, then I would like to see those patients. If they are complaining as a sort of symptom complex of menopause, along with lots of other symptoms, if it's intermittent, they have a bit of hearing loss, we like to rule out the things that we can fix and reverse. So examine the ears, make sure there's no outer ear obstruction, that there's no wax against tympanic membrane, because if there's wax against the eardrum, that can cause tinnitus in itself. Is there any middle ear problem? Is the eardrum retracted or bulging, or is there fluid? And then secondarily, what's their hearing like? Simply, is there a difference between the two ears? If there is, then that should be investigated with a hearing test, simple hearing test. In any Boots chemist will get you or Boots will do a hearing test. And then depending on whether there's hearing loss, that's very easy to reproduce. Now, there has been some research done, albeit on a very small population of patients who were menopausal women who had symptoms of menopause that had been diagnosed by a menopause expert. And they also had their tinnitus handicap index calculated. And as you know, we've talked about this before, there's a quantifiable how troublesome is your tinnitus. And for example, the scores were averaging about 50 out of 100. When they went on to HRT, their scores fell from 50 and 58 down to 12, 14. And the perception was that the HRT positive effect on the endolymph was neuroprotective and stopped this fluctuation, which stimulated this perception of sound when there's no sound present.
So HRT actually could help tinnitus.
There's certainly some convincing evidence that it has been symptomatically evaluated as being protective. And the theory behind it is that it's protecting the neurological pathways by reducing the fluctuations in fluid, in endolymph, in perilymph, and in the transition, and also hearing. You know, HRT has been known to improve hearing. There are also studies out there that say it's caused some evidence of hearing loss, but that's never been borne out or accepted. And so we don't really recognize that as a distinct entity. You might find a case report, but it's not a randomized controlled trial.
Yes. Yeah.
The other thing to just mention, sorry to interrupt.
No, I was just going to say, you mentioned one or two really simple things that could be done as well, like avoiding too much caffeine, look at salt in diet.
Absolutely. So good sleep hygiene is really important. So there's a definite link between insomnia and tinnitus. If you don't sleep well, is it because you've got tinnitus, or is it because you're not sleeping well and you're now aware of your tinnitus? And once you are aware of tinnitus, you really do need to make it your friend. It's very often not serious. Once you acclimatize to it, and if you're not tired, not stressed, not too anxious, then it will be less obtrusive. It never necessarily goes away, but there are lots of things you can do about it. So when we've ruled out all the worrisome things, then you can have some behavioral therapy. There are some fantastic apps out there that will track your symptoms and remind you that this is not something to worry about. It's always good not to leave yourself in a quiet environment if you've got tinnitus, because if there's no external sound, then your brain will process what it perceives to be the endogenously produced sound. If you're in a noisy environment and you're trying to focus and you've got some hearing loss, if you amplify the loss of hearing at the right frequency, again, you're processing again. Your brain knows to process sound from outside rather than sound from inside. And so those things go away.
Okay, that's interesting. And I wonder if I could just weave something in here. So Jacqueline, good evening. She's mentioned her tinnitus started 6 weeks into taking HRT had to
Okay.
have a brain scan, and the guy doing the scan said he had many women who get tinnitus after starting HRT, and it's on tinnitus.org. Have you come across that?
I've heard people comment about it. Yes. I don't know whether there's any scientific evidence. Certainly, I've read the literature broadly. Medication changes can cause disturbance to the fluid balance in the inner ear and to the fluid balance in the middle ear. And, I think a lot of people comment on things. It's quite possible the HRT is not necessarily directly affecting it.
Yeah,
It- it's cause and effect really, and I think if the brain scan is normal, that's very reassuring for a lot of patients. And again, tinnitus is how you manage it, is very much how you, if you say to yourself, okay, this is not something to worry about, it's
yeah,
not life threatening.
yeah,
We do know that vascular spasm in that area that causes migraine is associated with dizziness, and that is often seen in menopause. Um, but any big fluctuations in female hormones are associated with migraine and have been associated with migraine in the past. So women at different stages of development can experience, if they're sensitive, can develop migraine. And the theories behind the migraine development and tinnitus are probably one and the same thing, if you like.
Okay, so it's the same process. Because
Yeah,
I
and
was just thinking, you can be on HRT and still have the hormone fluctuations. The HRT is only really topping up that deep trough
precisely.
while your estrogen is still bouncing around up and down around it.
Yeah, and I think in the perimenopause stage, you might find that there's an increase in those symptoms. And we often consider, well, is that menopause or is it perimenopause? We're not measuring like for
Yeah,
like, and everybody is ever slightly different in terms of one size doesn't fit all. If it did, then we wouldn't have these problems in the first place, and it would be very easy to eradicate them. I
yeah,
think one of the other things to do is to um, do lots of mindfulness. Your heightened awareness and anxiety state is going to make all of your symptoms, no matter what they are, worse. And I think tinnitus is no exception in that. And I certainly find when we've reassured people that their tinnitus is not sinister, it doesn't reflect an underlying problem, and simple measures help to get rid of it, then that does a lot in itself for helping the patient to manage those symptoms going
yes.
forward.
That's incredibly helpful. Thank you. I think we should move on to dizziness, but is there anything with tinnitus that we should wrap up on?
I think I've pretty much covered everything in my in
Yes.
my
Yeah.
preparations for our discussions. Like I say, it really is about understanding and
Yeah.
making a plan, mapping your tinnitus. If you're acutely aware of it, then when is it at its worst? Can you attribute it to anything in
Mm,
particular? Did you have a particularly bad night's sleep, and is it much worse today? Are you stressed about something else? Have you drunk too much caffeine? Have you not hydrated sufficiently?
yeah.
um, have you taken other medication? What do you do when it's bothering you? How
Yeah.
do you de-stress, or how do you find yourself in the right circumstances for you? Exercise has been shown to be very effective in the management of tinnitus,
Mm,
um, just because it gives you a little bit of headspace. And if you're out and you're listening to headphones, you're stimulating your hearing, sometimes often at a louder level than normal, so
mm,
that can bridge the gap. But
yeah.
tracking it is very advantageous because it gives you control and it allows
Yes.
you to compare. The Tinnitus Association has some excellent, helpful advice. Tinnitus retraining therapy is something that you can pursue, and a lot of it is now done online since COVID, so it's possible to
Yeah.
engage with that through the audiological services, and your GP can refer you directly to audiology for tinnitus retraining therapy.
Yes. Brilliant. Thank you. And everybody listening, we're covering a huge amount of information. It's absolutely fantastic. Thank you so much. We will be putting this video on the website And we will also, I'll produce a transcription where you can have the written information. So rest assured. So I think we should move on to the one of the other really vague but tricky symptoms of dizziness. Many women will say, just throw in that they feel dizzy on top of everything else. Please, Vicky, an ENT approach to dizziness.
So we're very prescriptive about dizziness and ENT. There are only 5 symptoms: hearing loss, pain, discharge, dizziness, and tinnitus. Those are the five.
Yes.
So it's a quite a straightforward, simple subject.
Yeah.
Dizziness to me is something that the patient describes, and it doesn't mean the same thing. So I always ask the patient to describe to me in their own words exactly how they feel. The more difficult it is for them to describe, the more likely it is not to be an ENT symptom. So ENT dizziness is true rotational hallucination of movement. And it's based on the fact that your peripheral vestibular system, which is your semicircular canals, which are close to your cochlea, as we described before, they're designed to detect acceleration and deceleration in head movements.
Mm-hmm.
So the reason you can stand on one leg and close your eyes and not fall over is because your neurological system, rather, in conjunction with your vestibular system and your visual components, are all working together. Now, any one of those that's not working properly can disrupt your sense of balance. So balance disturbance and dizziness are not one and the same thing. Lots of people complain about lightheadedness. Lightheadedness is when you feel transiently a bit dizzy, and you might see stars, you might move suddenly, and it's often related to neck movements, stiffness in the neck, pain in the neck, and it's self-limiting, it lasts seconds. True rotational vertigo, where the room spins on an axis
Mm.
and you can't focus and your vision is disturbed, is from your inner ear. And that is one of your vestibular semicircular canals is not stimulating. It's not sending the right messages. So your brain thinks that you are moving when you are standing still. So the world appears to go around you.
Mm.
And that can last minutes, seconds, minutes, or hours.
Mm-hmm.
If it's seconds, it's quite likely to be benign paroxysmal positional vertigo, thought to be related to a bit of chalk-like material developing, which moves around as you move your head or as you turn over in bed from left to right. Very rarely you get a hallucinant movement up and down, but that's really unusual and associated with the posterior semicircular canal, not well described.
Mm-hmm.
The type of vertigo that I see can be viral, it can be vascular. So you can have cold and you get an ear infection, and the infection goes into the inner ear, and you get a viral disturbance, which is an inflammation of the lining of the inner ear. That will make you acutely dizzy, and that goes on for days, not minutes or hours. Then we talk about vestibular migraine, where patients get some kind of vestibular aura, maybe a loudening of their tinnitus, maybe a pressure sensation in the ear, and then sudden onset rotational vertigo. And it lasts for several hours, a bit like a migraine, isn't always associated with headache, and then can completely disappear, leaving you feel very hungover and,
Mm.
and like you've had a migraine, but without the headache.
Mm.
I'm increasingly diagnosing that. And I wonder whether that has more of a hormonal background to it. And the fluctuations in hormones as we transition into menopause may well explain some of the aggravating features that result in patients describing this kind of dizziness.
Yeah, certainly I see lots of women with vestibular migraine. I think increasing numbers actually that
Yes,
work can worsen in the menopause transition,
precisely.
probably, but again, that fluctuation.
And it's the fluctuations, and if you like, sometimes it tries to mimic an old-fashioned menstrual cycle but doesn't quite make it, and maybe there is some variation in that. And there's no doubt that as long as the patient has no neurological deficit and no cranial nerve problems, and no relationship to other symptoms like numbness, weakness, headache, or nausea. That's the other thing. Vestibular migraine or vestibular symptoms often make you very nauseous. So
Mm.
dizziness without nausea is unlikely to be coming from the inner ear. What
Okay.
do we do about it? Well,
Yeah.
again, we investigate it. We take a history. And most of the diagnosis of dizziness is based on the history, the characterization of the symptoms, the duration, what aggravates and relieves it, how often it happens. Do they get any fluctuation in hearing? Do they get any? Because Meniere's disease is just another bucket term, but to have Meniere's disease, you have to have 3 out of 5 criteria to be diagnosed as having Meniere's. So a lot of people describe Meniere's symptoms which overlap with symptoms of vestibular migraine, which overlap with potential dizziness that may be related to just a transition into menopause. So as long as the symptoms are self-limiting, and if it's transient and lasts just seconds, minutes, the eyes flicker and then they go back to normal, then good exercise, so Cooksey Cawthorne exercises or an Epley maneuver, will move the little chalk particles into what we call the ampulla of the semicircular canals and settle everything down. That is very easily done, and you can do auto Epley maneuvers. There's all kinds of video footage on YouTube teaching you how to do it. I
Yes.
often put patients through those exercises
Mm-hmm.
in the first instance. If it doesn't get better and it lasts any longer than that, then you have to be thinking about something else.
Mm.
Does HRT make a difference? I don't honestly know, because I don't prescribe it just for that reason.
Mm.
But I certainly take it into consideration depending on the patient population that I'm treating. And I always talk about low salt, low caffeine diet, because
Mm.
that can distend the inner ear endolymph perilymph barrier and cause stimulation and the hallucination of movement. And it's very disabling and very discombobulating for
Completely.
the patient,
Yeah.
you know,
Yeah.
finding the ground for moving underneath you. Now, disturbance of balance is something else and may well be cerebellar and more related to neck. Transient sudden changes in your head position can reduce the blood flow to the cerebellum and make you feel, oh, I'm going to go a bit funny, and then it passes off. So
Yes.
there are lots of other things that have overlapping symptoms that need to be excluded and are
Yes.
easily done so in a good history taking.
Yeah. And Vicky, there's been a question. Can you just say the 2 words again for the 2 different exercises?
Oh, yes.
Yes.
So there's an Epley maneuver. If you are turning over in bed and feeling that the room is spinning around for a few seconds to minutes, you probably have benign paroxysmal positional vertigo. And if you go through the Epley maneuver, where we suddenly jolt your head underneath with the ear that's affected undermost, and then we put you through a 360-degree rotation, which is not for the faint-hearted.
I can remember trying to do it as a medical student.
Yeah. So you can teach patients to do it themselves so that they lie on their back with the under ear. Say it's your left ear, and when you turn left, everything goes round. So you put the left ear undermost, and then you rotate shoulder 90 degrees, but keep the ear in the one place until you've done a 180-degree turn, and then you keep going till you find yourself turned around. And again, the Epley maneuver is online. You
Yes.
can Google it on YouTube, and you can do some of those things at home. Cooksey Cawthorne exercises are an extrapolation of that. They're a slightly gentler process, shall we say, not quite so traumatic. And the trick to getting the chalk particles to move is to stay in the position that you turn into that precipitates the symptoms until they wear off.
Okay, that's really helpful. Thank you. And I was just having a quick look on the chat.
Yes.
Somebody's Heidi. Good evening, Heidi. Saying feeling dizzy. I felt I think it's feel dizzy when sudden movements and
Yeah.
also get itchy ears.
Yeah.
Is there yeah.
So the relationship between the two, not direct, but itchy ears, skin changes during the menopause, very common, loss of collagen, change in the hydration of the ear canals. that can cause itchy ears, horribly itchy ears. Simple things for that: antihistamine for the itch, because we don't actually want you to put anything into your ears.
Yeah.
If the skin around the ear is in any way broken, then topical creams to just simple emollients, very useful. Please don't instrument your ears. They're designed to clean themselves. Anybody who puts cotton buds in their ears creates potential problems, and people can be very fixated. I've seen all manner of things, people using epilatory creams down their ear canals to reduce the hair in their ear canals. And, you know, it causes all manner of problems.
Yeah.
The body is designed to have flora, bacteria that are in harmony in your ear canal. If you start scratching, then you introduce the, you know, potentially harmful bacteria. You disrupt the skin barrier, and it results in local infection, swelling, itching, and
Yeah.
blockage of the ear canal.
Yeah.
So again, I think the itchy ears are not necessarily related to the dizziness, but that doesn't mean you can't have both.
Yes, yeah, and simple emollients would be things like zero base,
Zero
aqueous
base, yeah.
cream,
1%
yeah,
hydrocortisone if the skin is actually cracked and inflamed and flaky and looks eczematous. But
yeah,
if it's just simply dry skin, then
yeah.
good hydration, and careful with things like shampoos and things going into the ear, changing them. Sometimes that can be enough to just irritate the skin.
Yes, okay. I wonder if we have gone over slightly, but I wonder if we just spend a couple of
Sure.
minutes. Is there anything that's crucial that we need to say about vertigo?
The only crucial thing I would say about vertigo is take take time to work out what kind of
Yeah,
symptoms you have and track them to see if there's a pattern. Because if there is a pattern, present early to your GP,
yeah,
describe them, and they'll easily be able to decide whether they're true rotational vertigo and coming from the inner ear, and exclude all the other things that need to be excluded. Because unfortunately, diagnosing these as components of a menopause symptom complex are by a process of excluding all the other potential issues.
yes,
It's always
yeah,
wise to take advice. Um, um, Dr. Google is not great, um, because it just triangulates. I mean, if you put tinnitus in, you'll always see tumor of the inner ear. But that is the least likely cause of tinnitus, and the most likely one is hearing loss. Um, and I
yes,
suspect when we understand more about hearing pathways, which we're beginning to understand more about, how does it work? We didn't talk about the estrogen effect on the brain, but that has something to do with the perception of dizziness, the perception of sound. That's all a neurological interpretation. And so brain fog, all those other symptoms that we would experience, that's not unusual if it's related to estrogen receptors. Then if your focus is disrupted, then your perception of sound is going to be altered. You know, these are all sensory phenomenon that we experience, that if they are if the theory is to be believed, then it's not unreasonable to expect hearing and our balance to be disturbed in a similar way by the same mechanisms, because it's all neurological pathways to the brain.
yes. That's fantastic. I think we are going to, I'm really sorry, everybody who's asked quite specific questions. I think we need to wrap up. And so thank you. But I think if there were I think what I've taken from this is that estrogen can have an effect on hearing, on tinnitus, on vertigo, on how the nerves transmit from the brain. And we know around our body, so why not the ear?
Yes.
But also tracking symptoms, you know, that GP appointments are not long appointments. And if you
No.
can think about it beforehand and track what's been going on,
Yeah,
then
and also don't be afraid to say you can't characterize it, because that in
yeah,
itself tells the clinician a lot about what kind of problems it is. You know, palpitations can make you dizzy. Your blood pressure can make you dizzy. All these things have to be considered into the mix. But it's very easy for the ENT surgeon to say, well, if it doesn't go round and round in a circle, it's not specifically the ear that's the source of the problem. And that's one exclusion, if you like, and then we can progress from there.
yes,
But I do believe that that there is no doubt that there is some role of estrogen in all of this, either directly or indirectly. And there are lots of other ways in which we can help manage these symptoms so that they don't become intrusive and disruptive to our normal lives, and we can proceed to live happy, healthy, long lives, especially as women, because we're predestined to live a lot longer. So we have to get to grips with these symptoms early.
Yeah. No, brilliant. Thank you so much for your time.
Oh,
That
you're
was
so welcome.
absolutely
Thank you very much for having me. It's a pleasure.
tremendous. Yeah. No, thank you. And thank you everybody for joining. We will post this on our website. I will write it up as a transcript, as a blog, so the information is all there for you. And yeah, no, thank you very, very much for your time this evening.
Nice to see
Thank
you.
you.
Thank you all for coming.
Thank you. Bye now.